believe there comes a time when everything just falls in line. We live and learn from our mistakes. The deepest cuts I gave our faith. Now I believe there comes a time when everything just falls in line. We live and learn from our mistakes. The deepest cuts I give our faith. Now I believe there comes a time when everything just falls in line. We live and learn from our mistakes. The deepest cuts I give our faith. Now I believe. Jim! Woo!
Yay!
Can we see you on the screen, Jim?
Not at the moment.
Oh, put yourself on the screen.
I think I'll knock everyone off if I do that. There'd be too many.
Welcome to ReneMarie Shokalak in the normal fashion. We're so happy to be back with Jim from Village Connection Studios in Long Island. We took a kind of a hiatus, not really planned, but we kind of took a hiatus because of scheduling issues and scheduling problems and all that kind of stuff. And but it was a blessing because my daughter got married and I was able to set our May 2nd keep the conversation going, which before I introduce anybody or welcome Judy, my co-host, to the show, Jim, I want you to put up that, because that we're rocking with that. We're rocking with that. And everybody who's except for Dr. Libman, he's invited. We haven't invited him yet because we haven't had a chance. However, everybody on this show is invited and a part of it. And even if you can't attend personally, Dr. Libman, we'll put a video up of you. So, Jim, show that photo.
It's
show
up.
that photo. Is it up?
It's up now. Yep.
Okay. So we have how many did I say, Ginny? 28.
28, I think you said, yeah.
28.
Wow.
And on this, the last one was a gift to me in the world, Dominic Cortellessa, who is, I haven't broadcasted that yet. I haven't sent that out. And actually we had a guest last night on from Australia, Nicole
Yates.
She was phenomenal. And she's going to be a part of that show as well. So we just keep rocking. I don't know. Can you see it, Dr. Libman? Can they see the screen of who's on?
Yes. Let me just get it back up there. I'll show everyone, I think.
Yeah. I want everybody to take a quick look. That is so, and Judy and Ginny did such incredible work, especially Judy.
Oh yeah.
How's that?
That I can see.
Everyone can see that?
Stroking.
Yeah.
Is it clear on your end? Because it's not on my end.
It's a little fuzzy.
But that's okay. So that's the gist of it. I don't even need to speak. I mean, the pictures say 1,000 words on everybody that we have. And Dr. Libman, I hope you could attend in some fashion. It would be incredible. You don't have to let us know now.
I would love to. I'm just turning off the video for a second. I'm going to close the blinds behind me because I know there's a little bit too much light behind me. Just take a second.
It's okay.
You can see me.
Yeah, it's not bad.
Yeah, it's all right. Yeah.
Okay.
No,
Okay.
you're okay. You're
Okay.
okay. I mean, it looks like light shining in, but it's not. It's
Let
not.
me know. Let me know if it starts to obscure.
No. So what an incredible program we have today. And actually both programs merged together. And I actually rather it be that way because it adds more to a conversation and really has more insight and more thought patterns and more insight into the conversation. And back in November when we did a program with Catherine, one of our committee members, she shared that she had one of the reasons that she had a couple strokes, a TIA, and she had a stroke as well. And it was due to plaque. And at that point I said, like, why don't we invite Dr. Libman over? I got to close my phone because my girls are like going wild on the text message chain. And I'm sure it's going to be a lot. Anyway, so we said, well, let's invite Dr. Libman on because he's such a professional and really get his understanding of that. But let me introduce everybody. So, of course, we have Judy. Hi, Judy. How are you today?
Hi, very good.
That's good. Judy is my co-host. Judy does all the scheduling and all the booking and does an incredible job for our show. I mean, this show would not be what it is without Judy. It would not be what it is without Judy. And of course, Jim in the studio as well. Then we have Ginny, who is on the board as well. Hi, Ginny. How are you today?
Good, very well. Looking forward to more sunny weather. It's just such a breath of fresh air, literally.
Yeah. Ginny does all the tracking for us, and she works very hard on the telethon. That's really Ginny's, her part of the foundation.
Queen of spreadsheets.
Queen of spreadsheets. Then, of course, we have Ginny's doctor, Dr. Libman, who has been on our show a number of times. Doctor, how are you today?
How are you doing? Thank you for having me back.
Oh, we're happy to have you. We love you. We love you because you speak in understandable language. Like, it's not too technical. You really put things in the proper perspective for us to be able to understand the stroke world. So thank you so much.
Thank you for saying that, and now I won't send you any bills.
You put that in writing, doctor.
Okay.
Then we have our two 10 o'clock guests on the show. And like I said, I'm very happy that they streamed in. Let me introduce Keith first because Keith introduced me to Jim and Marcia. So hi, Keith. How are you today?
I'm doing great. How are you guys?
I'm good. How is your base program going? I still get the emails and stuff. And
I'm almost tired of saying this, but I'm so close to launch. There's been so much to it, but we'll talk more about that later. But thank you so much for having me on here. I appreciate it, and I appreciate everybody on here.
Yeah.
All you guys are wonderful. So.
Oh, thank you, Keith. So, and then Keith had introduced. I don't know how Marcia. How did you and Keith connect? And let me introduce you first. It's Marcia, who also suffered a stroke. Am I correct? With her husband, Jim. And we love the fact that Jim is a part of this show because it really does take your support team to be successful in any recovery. So it's a really important, different thought patterns on what the stroke world needs. And Jim is also going to be on the May 2nd to have that other portion of the thought patterns on. So Marcia, how did you and Keith meet?
So Lene Hunter called me one day and we got talking, and she invited Keith to join us, and that's how I met him. So for me, I met him because of a fluke. And I'm so glad.
Who is Hunter? Who is she?
So she runs Stroke, what is it, Stroke Oregon?
It's Stroke Awareness Oregon.
Stroke Awareness Oregon.
It's in Oregon.
Yeah.
Yes.
Okay. And how did you find that, Marcia? Because Keith's in Oregon, you're not.
So I got a call from her. She was just looking at LinkedIn and saw my name and said, "I'll give her a call." It's like
you're very prominent on LinkedIn. You really, yeah. Oh yeah. I see you all the time. All the time.
Good to know.
So, yeah, I'm just letting you know that your presence on LinkedIn is very prominent, and people do see what you're sending out. So that's really good. That's really good. So, Dr. Libman, let's get into the conversation about, how is the stroke world going? Because last year on the show was during the pandemic. I remember doing it from upstairs, and we were talking about the fact that people weren't coming to the hospital because of COVID. The strokes kind of got disappeared or visually disappeared. So tell us how that's flowing and how that's going.
Yeah, it's a very good question. And as you know, and it's been so well publicized, COVID has had this remarkable and very horrible effect on multiple different serious diseases. So not just the COVID itself, but the effects on stroke, on heart attacks, and other serious illnesses. And so, as you said, it looked like for a while, the people coming in with strokes, the numbers were dropping, which is unbelievably paradoxical when you think about what also has been so well publicized, which is that COVID is not just a respiratory disease. It doesn't just affect the lungs, which of course is horrendous, but it affects every organ system virtually in the body. And it has this profound, very powerful effect on blood clotting, so-called coagulation, the blood clots basically. So you would think that if anything, more people would be having strokes rather than fewer. And but fewer people were coming in for the longest period of time, and you can just imagine why. The first explanation that comes to mind is that people are just afraid. They're afraid to come to the emergency department. And now I'm going back a little bit pre-vaccine. Now,
Right,
thankfully,
right.
things are changing. But for the longest time, of course, people were even afraid to come into the hospital. So something would happen, and they wouldn't come in. And when it comes to stroke, there are other contributors. When you think about it, people are living alone more. People were isolating more. So older people who might have been living with someone before, maybe, you decided, well, it's not the safest thing, for a while, we better separate, you never know. So suddenly people are more isolated. So there's nobody else around to notice the symptoms and say, hey, you're slurring your speech. You may not be aware of it, but right now you're slurring your speech, or the left side of your body is weak. And sometimes people with weakness on the left side, because of the right side of the brain involved, don't even notice that anything's wrong. They could be completely paralyzed. And now, instead of living with someone or of having someone, let's say, visiting on a regular basis because of COVID, now they're isolated. So they don't recognize the symptoms. Not only that they're afraid to come into the hospital, there's no one else around to recognize the symptoms. And aside from not recognizing the symptoms, there's no one else around to call 911. And everybody knows, you could be paralyzed, you could have lost your speech, you could be lying on the floor, unable to walk, unable to get to the phone, etc. There are all kinds of things that people speculate contributed to this weird drop in people coming to the hospital during COVID. And I think, as the COVID, as this pandemic has gradually lightened, and we saw a bit of a remission, even before the vaccine, just according to the natural history of the disease and people taking precautions, etc. Things were getting a little bit better. And now, as you know, in general, the numbers are dropping, with some exceptions, as you know, also around the country, unfortunately, where things are not exactly improving to the degree you would have hoped, because of lack of vaccines or perhaps because of lack of precautions. But I think the overall trend is towards improvement. And the same holds, just for example, at LIJ, where I've been recently. 3-4 weeks ago, we had over 200 COVID patients in the hospital.
Wow.
A lot of them on ventilators. I would walk through these massive rooms with 120 patients in a room, everybody on a ventilator, some turned upside down, lying on their stomachs. It helps them to breathe. Many of them simply unconscious and virtually comatose for weeks and weeks and weeks, and sometimes for months because of the COVID itself and the effects.
When was this, Dr. Libman? When was this?
Less than a month ago.
Wow.
Yeah.
Wow.
About 200. And we're now down to about 85 or so, 85 to 90. So it's fluctuated a little bit, but it went from 200. And then I remember about 2 weeks ago, we were about 120. And when I was there on Friday, this past Friday, it was about 85 to 90. And it's just this horrendous picture. It looks like something out of what you see in old movies and photographs when you see patients on ventilators from polio or something like that, except they're not just on ventilators needing to breathe. Most of them are unconscious. And now some of them have had strokes because of the clotting, the tendency to clot from COVID itself. And that's when I get involved. I'm a stroke neurologist, so I'm not getting called in just because they're in comas or because their lungs are half destroyed or hearts or other organ systems, being attacked basically by. It's this horrible picture of over 100. They've opened up these extra parts of the hospital still to accommodate the COVID patients. So hopefully they can keep, COVID patients separate from the rest of the hospital. It's almost nightmarish, and I've been seeing it for a year, and you still don't get used to it because it's not part of the way the hospital is normally set up. But again, not all gloom and doom, despite what I'm describing. I mean, the numbers are falling. Patients are still getting COVID. Patients with COVID are still having strokes. They can sometimes have mild COVID and they get strokes. They can sometimes have severe COVID. That means they're comatose, and it's hard to recognize the stroke until somebody says, well, they're not waking up. Maybe we should get a CAT scan or an MRI, and suddenly you find that they've had a stroke. And that's not usually the whole explanation for them being in coma, but it may be an explanation for them not moving one side of their body, which suddenly you realize they're not only in coma or they're unconscious, but every once in a while you'll see them move the right side or the left side, but not the other side. Right. And that tips everybody off that there's something going on. Wow. The tricky part about COVID and stroke, last thing I'll mention, because I'm sure we're going to cover a lot of different topics. The really tricky part is, you've read a lot about very sick patients in the hospital with COVID. Now, forget stroke for a second. And the question is, they're all getting to have a tendency to get clots in their legs, in their lungs, everywhere. And there's all kinds of studies going on. Should they be on low doses, high doses, medium doses of blood thinners? As soon as they come into the hospital, should these COVID patients be on various doses of blood thinning medications to try to prevent blood clots in the lungs and blood clots everywhere, not specifically for stroke, just to keep them alive? The tricky part about stroke patients, what separates the type of patients that I care for and that all neurologists and particularly stroke neurologists care for, is that COVID not only has an effect to cause clotting, but also has an effect to cause bleeding. And and remember, there are two types of strokes. There's clotting and blockage types of strokes and bleeding types of strokes. And the huge dilemma that all the experts in other areas of medicine don't have to deal with. And so their recommendations often don't apply to neurology patients with stroke, is that you can bombard a patient with COVID with a lot of blood thinners to prevent clots in the legs and prevent clots in the lungs. But once they've had a stroke, if you do that, you may be encouraging bleeding in the brain. Wow. That is the other side of the coin. The flip side is strokes due to bleeding rather than to blockage. So from the stroke standpoint, we're always walking a tightrope. And what is the right thing to do? And what's the balance between and how much blood thinning to prevent blockages versus not encouraging bleeding in the brain? And then the worst thing of all, which we've documented and seen and published in a paper that was published in the American Heart Association journal called Stroke. That's the name of the journal for the American Heart Association. We looked at all the stroke patients in Northwell. And, as you know, Northwell had actually just about the highest number of COVID patients in the world of any health system. And that's including China. Way up. We were, it was just huge. And we found an unusual number of patients with stroke who had simultaneous blockage types of strokes and bleeding strokes at the same time in different parts of their brain, which is almost, not quite, but almost unheard of in the non-COVID population. It's just so rare. You get bleeding types of strokes and blockage types of strokes. We know that, and you know how to deal with it when patients come in. But when patients have both at the same time, just imagine the dilemma in terms of treatment when you'd like to prevent more blockage, but if you give them more blood thinners, the fear and the possibility of worsening the bleeding in the brain, which is present at the exact same time, almost never happens in patients without COVID. So all I can say is we are all hoping that this COVID pandemic stops with vaccinations and with everything else, and we can go back to treating quote unquote normal stroke patients and doing our best with them, and not having to worry so much about bleeding at the same time as we are worried about blockage. We're always worried about it to some degree, but this has opened up an entirely new horizon, a whole new perspective on stroke patients. This really horrible virus, which fortunately still affects not too huge a population, but enough for us to see it. And as I said to you just less than a month ago, over 200 patients, not the 650 patients we had last March, April, May, and June, when every single bed in our hospital, except for one half of one floor in our hospital at LIJ, was COVID. Similarly, at North Shore, not quite to the same degree. And that's what I mean with opening up every single, we converted the medical library to beds for the patients. The auditorium where we would normally have conferences was converted to patient beds. And we had every single bed at that time at LIJ, 650 beds were all COVID patients.
Wow, that's incredible.
So just to put it in perspective, it's not pleasant now, but it's nowhere near what it was. So I do think we're going in the right direction, and God willing, we'll continue to go in that direction, because it has been nothing short of a nightmare in terms of COVID and for every single disease. But my perspective is from stroke, and it's been horrible.
Wow, thank you for that information, because that really does remind us of what's going on. I think the world is a little bit worn out and tired. They just want to go back to the normal, but you got to hold on a little bit longer to go back to that normal, because even though it was 650, a year ago, and it's still 200, it's still 200, and we could still get it. Has the variants changed any though, doctor? Is there less deaths from the COVID right now than there used to be? And then we'll get into the stroke, but is there less deaths? Are people getting sick but not dying so much from COVID?
All right, that's an excellent question. I'm going to answer it, and just with the caveat that I am a neurologist, and you're asking a more general COVID-related question.
Right.
And I can tell you from what I know, the answer is definitely yes. The death rate from COVID has gone down, and the reason is totally separate from the vaccine. So this is not a vaccine issue. The vaccine should prevent disease, and if you get disease, hopefully it's less severe. But even separate from the vaccine, the medical knowledge of how to treat COVID patients, of course, has improved over a year. And whether it's steroids or some of these antibody treatments that you've heard of, steroids at the right time, and even when to put a patient on a ventilator, not too early, maybe avoid the ventilator altogether, which may be causing further damage in some cases, and figuring out which patients will benefit from a ventilator and which patients will not, which patients benefit from lying on their stomachs. It looks weird, I can tell you, when you walk by and you see a bunch of patients, sort of sprawled out on their stomachs, and that goes on for weeks and weeks on end. But some will benefit from that from the lung standpoint. So the answer is my understanding is, as a neurologist, that the death rate from COVID has definitely decreased because we've learned about certain treatments that are effective. And then, as you know, the advent of the vaccine or the various vaccines, none of which may be perfect, some of which are really, really, really good at preventing infection in the first place, and many, and perhaps all of which, hopefully, will be effective to prevent serious disease, so that even if it doesn't prevent you from getting infected, if it prevents you from ending up in the hospital on a ventilator and dying, and it just gives you a mild disease, that's great. And the question, of course, in your mind and everybody's mind is, will these genetic variations, these genetic variants that you mentioned, where the virus mutates, which is nothing new, it happens to the flu virus, it happens to every single virus we deal with. It's nothing new, and it's no surprise to anybody. The question is, will that in some way circumvent the vaccine? And, there's a little bit of a hint here or there. It does or it doesn't. It does or it doesn't. And this country or that country, maybe it does or it doesn't. The vaccine's still effective, not quite as effective. The fact is, you know as well as I do, like everything else with this disease, it's a brand new disease. And unfortunately, time will tell. And everybody's hope is that, again, the vaccines will prevent at least severe disease, even if it can't prevent every infection, as the genetic code changes in these viruses. Of course, it becomes a little harder for your immune system to recognize it. But if it recognizes it partially, but not fully, and can sort of dampen it down, because now it's got a little different signature, it's got a little different identity, because the genetic, it's changed a little bit. But but either the vaccine can handle it, and the people can handle it, and you don't get as sick, or as you know, many of these companies are very hard at work, just as they are with the flu vaccine every single year. There's not magic to it, but they are doing a fantastic job in looking, here's the variant, here's another one, here's the 3 top ones that we think are going to cause the most problems, and you just tweak the vaccine a little bit so that then that informs your immune system. Now you don't just recognize A, recognize B, and C, and recognize them all perfectly, so that, and that's the next step in vaccine boosters and things like that. And who knows, maybe we'll be going back, I would guess, once a year, and maybe it'll be in another 6 months, and maybe it'll be once a year after that for a while, like the flu vaccine. Hopefully by then, everybody sees, of the millions and millions and millions and millions of people vaccinated around the world, the vast, vast majority are doing fine. Put people's minds at ease. Everybody understands. Everybody's nervous. Some of the technology is new. Am I going to grow another arm out of my shoulder? 3 arms might not be so bad. I'm sure my employer would be happy. I'd see twice as many patients every day. But everybody's nervous. But the more people who are vaccinated, obviously, and the more time that goes by, and yes, you hear about an occasional allergic response, or the quote unquote blood clots from AstraZeneca, but 5 in 3 million, less than you might expect in the general population. The fact of the matter is, the evidence is pretty overwhelming that this vaccine is safe. As safe as any vaccine we've ever used, if not safer. So, but I know everybody knows, everybody's nervous. So a little more time goes by, more people get vaccinated, more people get comfortable, and I think that this will get under control, and everything we've seen and everything we've studied or published in journals, nothing would make me happier than it becomes a matter of scientific curiosity, that the historians will look back in the near future and say, hey, look at all those things that happened with COVID and stroke, or COVID and any other illness, and it'll just be something interesting to study in the history of medicine, like going to the Smithsonian Institute, instead of having to say, look at what we have to deal with right now. This is horrendous. And that's got to be everybody's hope.
Wow. Thank you so much. So I want to get into the conversation about the plaque. We'll do that in a few minutes, but I want to give Marcia and Keith the opportunity to share the reason for your stroke. Marcia, can you share with Dr. Libman what caused your stroke?
So I had a carotid artery dissection, and I'm told that 1% to 2% of patients have it. And I'm also told that in my case, they don't know what caused it.
Okay. And would you? Would you like me to address the concept of dissections?
Yes.
I mean, look, it's never good to have any kind of stroke. And dissections, it's interesting. So a dissection is fundamentally different from the quote unquote usual type of stroke. And I know we're going to talk about so-called plaques and things. Plaques, the generic sort of term, plaque would be hardening of the arteries. So on the one hand, you get this huge number of strokes caused by hardening of the arteries, technically called atherosclerosis, which causes plaque buildup of fatty tissue and fibrous sort of scar-like tissue and muscle and all kinds of things add up in the wall of the blood vessels, thin out the wall of the blood vessels, so thin out the tube rather of the blood vessel, gets smaller, makes it unstable, and makes it more likely to cause a blood clot to form in that area, which can then block off the blood supply or break off, travel up to the brain and block off the blood supply up there. That's hardening of the arteries or plaque. And again, I'm digressing just for a second because the discussion is going to be about dissection, but just to make the contrast with what is the more common cause, plaque, atherosclerosis, hardening of the arteries, which is overwhelmingly the same cause of heart attacks. Overwhelmingly, heart attacks have a much more kind of homogeneous, uniform cause. Plaques in the arteries of the heart, the coronary arteries that rupture, cause clotting to occur in those arteries. That's a heart attack. Strokes certainly have plaque and atherosclerosis, but then have this group of other causes that you don't see in heart attacks by and large, that you don't see in blockages in many other places of the body. And dissection is one of them. And the interesting about dissections, and I back up for a second, what is a dissection? So as opposed to a plaque, you're looking at something else that can interfere with the flow of blood, for example, in the carotid artery. Does it happen only in the carotid artery? No, it can happen in other main blood vessels that supply the brain. For example, in the back, it's called the vertebral artery. So the vertebral arteries travel up and supply the back part of the brain. The carotid arteries travel up and supply most of the front and side part and the upper part of the brain up here. So it's a major, that's actually about 2/3 to 3/4 of the blood supply to the brain actually from the carotid arteries. So carotid arteries, vertebral arteries. Then what is a dissection as opposed to a plaque? A dissection is actually a small tear in the wall of the blood vessel, meaning a tear inside the wall of the blood vessel, not in the tube of the blood vessel where the blood flows, which is called the lumen. Not in the lumen, not in the tube where the blood flows. It's inside the wall. And when that little tear occurs, like picture a pipe, but the wall of the pipe, like the circumference of the pipe, what forms that? That's a wall. There's something in it. It's formed by something. And the carotid artery has different layers, and it's tissue and it's muscle and it's elastic type of tissue that can stretch a little bit. And it's all kinds of tissue in the wall of the blood vessel that supports the blood vessel, that forms the wall of the blood vessel. A dissection is a tear inside that wall of the blood vessel. And when that tear occurs, as with a tear in your tissue, in your skin, in anything else in the body, you actually get a little bit of bleeding. Yeah. But the bleeding, because it's in the wall of the blood vessel, doesn't just go right away into the blood vessel itself. It's not like bleeding in your blood vessel or bleeding in your brain. At first, that bleeding is inside the wall of the blood vessel. And once you get that bleeding in the wall of the blood vessel, two different things can happen. That blood can then rupture through the wall of the blood vessel, and go into the tube, basically. Wow. Go into the tube itself where blood is flowing. But when that blood from the tear inside the wall of the blood vessel goes into the tube where blood is flowing, goes into the carotid artery, at that point it often clots. It forms a clot. And that clot can then now that it's in with flowing blood inside your blood vessel, can then go up, travel up the carotid artery. Now you have a clot of blood inside the tube, inside your carotid artery, travels up with the blood flow, goes up to another blood vessel inside the head, inside the brain, lodges there, and blocks off the blood supply. So
I have a question, Dr. Libman.
Yeah.
When you go for carotid artery operation and they're cleaning out the carotid artery, could a tear occur?
The answer is 100% yes. And sometimes when you go in, not just with an operation, sometimes when you just go in with a catheter to the carotid artery, let's say you want to put a stent in there, and I'm getting ahead a little bit in terms of treatments, you can stent the heart arteries. Well, if you have a blockage in your carotid artery, usually from, now going back to plaque again, usually not from dissections, but if you have narrowing and hardening of the arteries here, there are two ways to open it. One is with an operation and you clean it out. The other is with a stent, where you put in a catheter and open up a stent and it opens up the blockage. That can tear the wall of the blood vessel and cause a dissection. More commonly from an operation, I know this is a little bit of a digression and getting maybe a little ahead of ourselves, but when you're having an operation to clean out the artery, you don't usually cause a dissection by opening it up and cleaning it out, but you certainly can, just because you're kind of mucking around in there in the process of cleaning it out, dislodge a piece of plaque or a blood clot that can travel up and lodge and block off a blood vessel inside the head. So
what are the statistics on that? What are the chances of that happening?
From an operation, it's quite small. Again, you can give sort of global statistics, but it always depends who's doing it and which institution and which particular surgeon. But overall, in terms of complications, you're looking at probably a couple of percent. Partially, it depends again on the patient. Could be as low as 1 to 2%. Could be as high as 5 to 6% in certain cases. So not trivial, but in general, and again, I am digressing and we'll get back to dissections, I promise, in a second. In general, those operations to clean out carotid arteries, it's been shown over and over and over again, while there are risks, almost beyond a doubt, the benefits overall outweigh the risks, and people in general do very well and then have a very low risk of having another stroke. So definitely complications, but overall, overwhelmingly, the benefits outweigh the risks.
Thank you.
I have a question, Doctor. I mean, since this is there's no way to prevent this from happening. This is just something that happens. Am I correct?
No, are we talking back to dissections?
Yes, the dissection as with Marcia. I mean, there was really no way to prevent a tear, right?
Yeah. Okay, perfect. Well, let me go back. And the reason I'm moving my fingers once in a while, because unfortunately on my phone, in order to see everybody, sometimes So that's the disadvantage as opposed to the computer. So I just want to look at people. So I'm switching back and forth.
That's okay.
Just to get back to the dissection for a second, just in terms of the actual mechanism, and then to the question of how to prevent and can you prevent it, etc. So one possibility, as I said, is you get a little tear. The bleeding occurs in the wall of the blood vessel. That bleeding can then rupture into the blood vessel itself, into the tube, forms a blood clot, travels up to the brain, causes a blockage, one mechanism of stroke. The other mechanism from a dissection is that the bleeding occurs in the wall of the blood vessel. That's always how it starts. By definition, that's what a dissection is. A little tear, a little bleeding in the wall of the blood vessel. But instead of the blood clot forming and rupturing into the vessel itself and traveling up, sometimes the bleeding starts to push on the wall of the blood vessel and it pushes it closed. So imagine you have your pipe, you have your bleeding here, and it starts to push and push and push and push and push the blood from inside the wall of the blood vessel, starts to close the blood vessel just because of pressure on the wall, and it closes it off. And it's like having a really rusty pipe all clogged up, but it's not clogged up from the inside in this case, as with plaque, which is like a rusty pipe from the inside. it's in the wall and it's closing off the blood vessel. So in that case, it's not a matter of a blood clot breaking off and traveling up to the brain. It's the fact is the blood flow just stops. It stops because it's being occluded. It's being pushed shut, that blood vessel. That's the other mechanism of a dissection. So just, that's the basic mechanics of a dissection. Then you say, why does this occur? Look, in younger patients, in patients under the age, let's say, of 30, you know that hardening of the arteries and cholesterol and all that, when you're under 30, it's not a major problem. It may be in the background somewhere and you want to detect it. And any 25-year-old with high cholesterol, you probably want to start treating it. But for the most part, we know that 22-year-old young people are not walking around with serious plaque. They may have cholesterol problems. They may have, you got to address it, but they don't have plaque. That's occluding and blocking off their blood vessels. What they may have are dissections. And if you look at strokes in young people, which are less common than strokes in older people, but it's devastating. So you take strokes in young people, and they do occur. The most common cause of strokes in young people overall is dissection, because they don't have hardening of the arteries. They don't usually have these other heart conditions that I think we've talked about in the past. For example, atrial fibrillation, a particular kind of irregular heart rate, very conducive to strokes. Young people don't have that. For the most part, they don't have a lot of things that older people have that cause long-term hypertension and high blood pressure and smoking, etc., that leads to plaque. But young people get dissections, and older people can get dissections, and every age can get dissections. It's just that as a percentage of all strokes, young people have it as a very high percentage of all the strokes they get. Older people, nothing protects older people from dissections. Unfortunately, there's no reason why we should be protected as we get older, but there are so many other causes of stroke. Sounds kind of depressing. So many other kinds of stroke, causes of stroke as we get older. As a percentage, dissections become lower on the list as we get older, but it can affect anybody. Now, there are really two types of dissections. And this goes directly to your question is, can we do something about it or can we not do something about it? And that's kind of a branch point, two types of dissections. One type is called traumatic. That means you've had some kind of trauma. And trauma doesn't have to mean that, you know, a bus ran over your neck, which could damage your carotid artery. I wouldn't want to test it out, but that is trauma. But trauma also refers to kind of a subtle kind of trauma. And it becomes really weird to think about, but it's almost definitely true. So think about the old days before cell phones, and now even with cell phones, but especially in the old days for most of us who used normal phones. If you remember, you'd be on the phone and you'd be holding it and you didn't want to hold your hand up for too long, and you'd end up going like this. And you'd kind of walk around with the phone under your ear with your neck bent a little bit. And some people even do that with cell phones. That simple maneuver has been associated with enough trauma, so-called trauma, stretching the blood vessel a little bit. You do that for 3 hours and you suddenly have a 25-year-old who comes in with a stroke. Alternatives are described with, and I see Keith doing something, and there is something called beauty parlor stroke, which has been known about for years and years and decades, more so with women than men, but it sounds kind of sexist. I think it can definitely happen to anybody. You go in to have your hair washed at the hairdresser, and you know how they extend your neck like that, and it's a real hyperextension of the neck. Neck goes way back, and in some people, for whatever reason, well described, they come in a day later with a stroke, and they've had a dissection in the back part, which is the vertebral artery, because that's the one that's stretched the most with extension of your neck. That's beauty parlor stroke. Sometimes people playing golf over and over again, tennis, painting your ceiling, doing an oil change.
I want to ask you a question, and then I want to show the video for plaque, because we're really
sure.
it's been wonderful. But So if there's a beauty parlor stroke and there's a golf stroke, and I mean, how do we prevent that? I mean, those are things that as a woman that goes and gets my hair done, I don't want to put my head back with the risk I can have a stroke, another stroke.
Trust me, I completely understand. And when I want to have the 5 hairs on my top of my head I have left washed, I would go to the beauty parlor too. I'm deliberately not putting my head down because I don't want to be embarrassed. So listen, that just leads, and we'll get to plaque. I know we got to get to plaque.
Yeah, because Jim's going to show a video. I want to show the video before. Go ahead, but tell us how we can prevent
just
it.
To finish with the dissections, what I'm calling, that's trauma. Most people, so there's trauma, and then there's trauma like this, and you're holding your phone. Most people don't call that traumatic. They would call it spontaneous. Because look, you were just leading a normal life. Everybody does the same thing. Something happens. So we call it spontaneous, even though, okay, you've been holding your phone like that for 3 hours. Maybe that did something. But the reality is there are probably a portion of the population who genetically, you can't identify it genetically, and it doesn't run in families in that way, but they have some tendency, a slight weakness in the wall of the blood vessel. You would never know it until, unfortunately, they show up with a stroke. You find a dissection. You say, doctor, I did nothing. Well, you're holding your phone. The other one is, of course, did you go to a chiropractor, and did he take your head and turn it suddenly to one side? Unfortunately, a small percentage of patients, of people who go to chiropractors and have this manipulation of their necks,
Wow.
a small percentage, not to denigrate chiropractic, they do great work. But some people, when you do those rapid movements of the neck, will show up with a dissection, and they've had a stroke from the dissection. They are probably predisposed. So when you ask, what can I do to prevent it? Look, the real answer is, unless you want to lock yourself up in your bedroom and never emerge and don't do anything for the rest of your life, unfortunately, you're never going to know. The vast majority of people, of course, do everything and never have a dissection. Once you've had a dissection, and I guess that would be for Marcia, you're going to be a little more careful. Whether you identified something in the first place, some maneuver, some unusual movement of your neck, or something, whether you've identified it or you haven't identified it, once you've had a dissection, you're going to be careful, and you're probably not going to hyperextend your neck in the beauty parlor. You can exercise, you can do anything you want, but you're going to be conscious of any extreme movements, bending, particularly back or to the sides. You're just going to be conscious of it. And then you're going to lead a normal life, and you're going to have normal activities, and you're not going to lock yourself away. And chances are you're going to be fine. And the good news about dissections, if you look it up, the good news about dissections in general with stroke is the rate of recurrent stroke is very, very low. And in fact, most of them occur in the first month or two. Even if you look a year out, what happens at a year, a couple of percent have another stroke. Most of those have occurred in the first month or so. And if you get a year out, let alone 2 years out or whatever it is, and I don't know where you are at this point, Marcia, but the fact is the recurrence rate of stroke after dissection is very, very low. Very low.
Marcia, did you want to say something?
So I'm 7 years post-stroke.
There you go.
Perfect.
At this point, you could go parachuting from a plane. You'll be fine.
No.
Marcia, are you thinking about doing that?
No.
And Jim is like, no, she's not.
She's not doing it.
That's good. That's good. But just be aware that you probably can, and nothing will happen.
Good. Nothing will happen as far as a stroke.
That's exactly right.
Be clear.
I'm not making any guarantees about anything else.
Jim, could you show that video of Catherine talking about plaque, the fact of her story? Show it for us.
Like overtaking your body. You can feel it coming on almost, but you're just confused about what's going on initially. In the ambulance and in the ER, I knew what was happening, which creates another level of angst, because you're saying, is this going to morph into a full-blown stroke? And, you start hearing, you've had a stroke, you've had a TIA, you don't even know what a TIA is. You hear all the medical jargon. And although, I was a medical social worker and I was aware of a lot, having worked with stroke patients, some of it it's very intimidating and overwhelming. But that team down there worked so hard to assuage all of my fears and my anxiety that, that was comforting. So I stayed there for about 3 days. They ran the necessary tests. They ran, CAT scans and MRIs and my heart, blood work, constant monitoring of blood levels, blood pressure, etc. And then I was released to go home. Going home the first time was like, oh, this is wonderful.
Before you continue, what triggered it? What was the diagnosis? I mean, I know you had TIAs, but what was the cause of the TIAs?
The cause was a buildup of plaque in one of the vessels in my brain on the left side. And there really wasn't anything they could do.
In your carotid artery?
There was some in the carotid artery, but that was not deemed as the initiator of the stroke. The initiator of the stroke was really the plaque that had built up in the vessels of my brain.
That's it, Jim, right? So we really just wanted to have Catherine to be a part of this show because there's various reasons that she couldn't be live. As you know, previously, we're supposed to do this in February, just to bring the attention to the plaque. So talk to us about plaque and about how we can prevent that as well.
Yeah, no problem. I don't know. I could not see the video, but I could certainly hear everything that she was saying. And plaque, so now getting back to plaque related to, and this is one of the most common causes of stroke as people get older. So again, to kind of differentiate it from dissections occurring certainly at any age, but as a proportion more common in younger patients, younger people. Now, as we age, almost everyone gets some degree of what we're calling plaque or hardening of the arteries. Just to put it in perspective for you, so it sounds a little gory, but if you look back at the Vietnam War, so now go way, way back, unfortunately, as you know, 18 and 19-year-olds were being killed in that war. And they were coming back to the United States and getting autopsies. And what was found in these 18, 19, 20-year-old kids who had been killed in the Vietnam War was that when you looked at their blood vessels, for example, the aorta, the main blood vessel that comes out of the heart, that's one of the easiest ones to look at, they had early signs of plaque or atherosclerosis, hardening of the arteries. And so that's why I said before, while it's not a problem in young people in terms of it's not blocking off their blood vessels at this point, it's not causing blood clots, and it's not totally occluding the blood vessels with a lot of plaque. The process of plaque and atherosclerosis, hardening of the arteries, no doubt starts very, very early. And
but can that be like at my age or earlier? Can that be tested to see if I have the tendency to have plaque or get plaque?
I mean, look, these findings that were seen in these kids, and I think they are kids, even though maybe 18, 19, 20, I guess technically they're adults, but they seem like kids.
They're kids.
Exactly. And it's the kind of plaque that's very, very minor that you can see with a microscope. And you can see it, but in the usual tests that we do, ultrasound tests and MRIs and CAT scans and things like that, that's really designed to look to see when the blood vessel is actually getting narrow. And you're starting to see a vessel that should be like this at 100% is now like this at 50%. All of our tests look at that kind of narrowing. And what I'm talking about is something that you see under a microscope, that you see the abnormal early formation of plaque, but it's not narrowing the blood vessels. So you can do an ultrasound and you can do an MRA and that kind of thing you can do, but you're not going to see anything happening to the actual tube of the blood vessel because it's not enough to narrow it. Chances are you're going to completely miss it and you'd be falsely reassured. So what you have to do in young people as well as older people is all the things that we do, which is check their cholesterol and check their blood pressure, because young people have high cholesterol and young people have high blood pressure, and the damage starts early. that was proven by these kids coming back, unfortunately not alive anymore, from Vietnam, and I'm sure the same is happening now in any other war. And you can see the earliest forms of plaque. And what do? You can't find the plaque, but you can find who is most at risk. And you can start to treat their blood pressure and their cholesterol. And if they're smoking, you can stop, hopefully advise them to stop smoking and help them to stop smoking, etc. And I don't necessarily mean, by the way, with blood medication for every single person. And you know very well, as I do, that the first place to start is with lifestyle. And if they're not exercising, they can exercise. And if they can lose weight, they can lose weight. And if they have some diet that's not too healthy, they can improve their diet. And there are many things you can do before you have to turn to medication. And sometimes you have to turn to medication. And fortunately, there are good medications around and pretty safe medications around. But that doesn't mean everything has to be addressed by medication. And particularly early on, there are things you can do. And ultimately, look, whether you do or you don't do, we know that in a large percentage of the population, you get a buildup of plaque. And that's the hardening of the arteries. And whether it's in the carotid artery here, the vertebral artery here, or as in the video, which I couldn't see, but I heard, I think she was describing plaque inside the blood vessels, inside the head. Why not? They're no different from any other blood vessel. So just as you can get plaque here, you can get plaque here. It causes narrowing of the blood vessel, or even without significant narrowing of the blood vessel, the plaque can be kind of what you might call unstable. In other words, it has a tendency to form a clot on top of the plaque, so that even if the plaque wasn't narrowing the blood vessel by 90%, which is clearly a bad thing, but it's only narrowing the blood vessel by 60% or by 50% or whatever it is, it's causing some abnormalities in there that can cause a blood clot to form. And then you don't have to block off the blood vessel 100%. Once you form that blood clot, wherever you're forming it, it can travel. And once it can travel, it can go to another blood vessel downstream and block off that blood vessel. And that's one of the most common mechanisms of stroke. Why? How? What's the mechanics of how they actually occur? And sometimes you get a plaque like that. And when it's not too severe, all you have to do is treat first with lifestyle and then ultimately with medication. Many of those people will do very, very well taking an aspirin a day, controlling their cholesterol by lifestyle or often by medication, like one of the statin type of medications, Lipitor, etc., those types of meds, making sure their blood pressure is under control. And suddenly, lo and behold, the same plaque that might have been dangerous is not so dangerous anymore. Should I pause?
No, Dr. Libman, Jim has a question for you.
Oh, sure.
So I was just, as you were saying all that, I was thinking of the current living and eating habits of the millennials and to some extent the post-millennials. What's your thought on their chances of the clotting aspect?
Now, that in terms of eating habits, you're going to have to educate me. What are you referring to? Is it like the Burger King type of eating habit, or is it some paleo diet or vegan diet or something else?
No, it's the like living in their parents' basement, eating chips and drinking sodas and playing video games, that kind of stuff.
Probably the video games are more dangerous than the diet. Anyway.
And just so you know, before you answer, we have 5 more minutes, okay?
Got it. I mean, look, your question is obviously a rhetorical question, and the answer is already in the question. And it's not, there's nothing magical to it, and it's not even in the neurological purview as much as in the purview of general medicine and cardiology and what's been known for years and decades and decades. Fried foods, not enough vegetables and fruit, heavy on junk food, processed meats, tons of salt and sodium, all bad. And if you had to look at anything, look, there are some people who believe in the healthfulness and even the ethical aspects of vegetarianism and this and that, and avoiding animal products and fruits and vegetables. That's almost definitely a healthy diet, but I know some people believe in it, some people don't believe in it. that's fine. It's hard to go wrong with a diet like that, unless you happen to be a vegetarian who eats nothing but spaghetti and tomato sauce all day. You may not be doing yourself any favors, but certainly vegetarian and vegan diets, if that's your inclination, almost definitely are healthier than heavily meat-based diets. And if you still want to include animal products, then as you've read and as you may know, if any diet is probably going to be healthy from the cardiovascular standpoint, from the stroke standpoint, it's going to be the so-called Mediterranean diet. Very little red meat, but if you want to include animals, then it's fish for the most part. Olive oil, and then a lot of beans and legumes and sort of fruits and vegetables. From the standpoint of stroke, and as a neurologist, I can tell you from the standpoint of dementia and just losing your cognitive function, there's so little that we can offer still. There's no magic bullet, but something like the Mediterranean diet has passed muster in terms of repeated studies, stroke prevention, heart attack prevention, and prevention of dementia, maybe Alzheimer's disease. If you had to look at anything, Mediterranean diet and exercise, physical.
I'd like to make a comment.
Yes.
I just want to really fast, in a couple of seconds, mention that foods that are high in trans fats are fried foods, processed packaged foods, cakes, pies, pastries, cookies, biscuits, margarine or butter substitutes, vegetable shortening, products with hydrated oils, otherwise known as trans fats. Eating more unsaturated fats would be avocados, olives, walnuts, some vegetable oils, including sunflower and olive, fatty fish, including trout, herring, and salmon, and follow other dietary tips like whole fruits and vegetables, nuts, whole grains, low-fat dairy, fish, and poultry.
100%. 100%. And as I think I might have said here at one point, I have to say it again, the patient saying to his doctor, doc, if I give up red meat and I give up alcohol and I give up smoking and I give up sex, will I live longer? And the doctor, of course, says, no, but it'll seem a lot longer.
Great ending, Doctor. We really want to thank you. You are so full of so much information. Ginny, I know you're just sitting back and letting the doctor share his wisdom.
Absolutely.
Thank you so much for bringing your doctor on to the show once again.
Dr. Libman, I will forward some information to you about that May 2nd program that Renee was talking about.
Very good. And it's a pleasure to see everybody, and it's always a pleasure. I'll do whatever I can to help.
Thank you for getting up early morning when you have a little bit of time off. We really appreciate it.
Yes, thank you so much.
Thank you, Dr. Libman.
Keith, I'm sorry we didn't get to your story. Maybe in the next program we have with Dr. Libman, you could come on and share your story. But I just really wanted to stay in line with the plaque, because that was Jim is getting prepared. Don't leave yet. So I just really want to thank everybody, and actually Marcia and Jim and Keith and Judy and myself will be back for the 10 o'clock show, which we're running a little bit over, but that's okay. And Dr. Libman, thank you so much once again for your wisdom and your education and your knowledge, and really for really keeping it updated and working to make the stroke world better. And that's what the May 2nd is about. The May 2nd is, let's keep the conversation going so that we can let the world know that everybody is working to better and to prevent strokes, and to bring some hope to those after they have a stroke, that there is life after a stroke, which Marcia and Keith will attest to, and Ginny as well. So we're so grateful to you. We really are grateful to you.
My pleasure again, and thank you for doing all of the work you're doing, because you're doing more than I could ever do to reach so many people. So I really appreciate it also.
Thank you. God bless you, Doctor.
God bless. And three,
God bless everyone.
We always blow kisses, and then Jim will go into the after show on 3. 1, 2, 3. Bye, everybody. We'll see you in a few minutes.
Stay well.
Mi amor, yo no entiendo por qué tú ni más que nadie sabe qué pasó en mi vida. Yo no sé qué tú piensas, yo no sé lo que haré, yo no sé lo que estoy perdiendo, yo no sé lo que va a pasar. No me puedes escuchar llorar solo sin ti, no me puedes oír llorar. El día que caminaste por la puerta, todas las memorias fueron. Mi corazón está vacío, como si tuviera ayer. No me puedes escuchar llorar solo sin ti. Mi corazón está sufriendo. No me puedes escuchar llorar solo sin ti. No me puedes oír llorar. Usted está en mi sueño por la noche. Por favor, no peleemos. Y es tan difícil para mí y para ti. Yo, ¿qué puedo hacer? No me puedes escuchar llorar solo sin ti. Mi corazón está sufriendo. No me puedes escuchar llorar solo sin ti. No me puedes oír llorar. No me puedes escuchar solo sin ti. Mi corazón está sufriendo. No me puedes escuchar llorar solo sin ti. No me puedes oír. No me puedes escuchar.